Yay Networks.
Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady, and we have a fantastic episode for you today. Not only because I think the episode in terms of its content is interesting, but as always, the content is only as interesting as the individual speaking about it. And boy, are we honored to have the world famous Dr. Babak Azizzadeh. Some of you may recognize him if you're watching this as, the doctor on Oprah. I mean, wasn't even sure if I wanted him on the show because he's awfully handsome. And, I really don't like any competition. But for the sake of the listeners, we've invited him anyways. So you can thank me later because he is a phenomenal physician and surgeon. I've known him for many years. Babak is incredibly well trained. He's ENT, then further trained in facial aesthetics. He runs aesthetic fellowships and has fellows or people that train under him. And amongst his many talents, one area that he excels in and is probably a world leader in is in the area of facial paralysis. That's a topic today, facial paralysis. And so what we're going to talk about is the A to Z of facial paralysis. People think of facial paralysis, they think of like Bell's palsy and things of that nature, but it's much, much more complicated. So this lengthy, long-winded introduction, Babak, welcome to the show.
Thank you, Rady. This is an honor. And definitely I cannot beat you in the handsome category, maybe some of the other categories. But
All right. Well, I appreciate that. I assure you we would have invited you back even if you didn't say that, but compliments get you very far. Babak, so let's just start out with the real basics. So as people are listening, they're like, what the hell is this facial paralysis crap? So give me a very basic explanation of what facial paralysis means and sort of, if you will, the mild, the moderate, and severe cases.
Yeah, so one of the most important aspects of our day-to-day life and actually our social existence is communication, nonverbal communication with others, smiling, laughing, showing sadness, showing anger. All of those are controlled by muscles in the face. We have 17 muscles on either side of our face that controls those expressions. And the part of the brain that controls that basically sends signals through a nerve or wiring network that basically activates these various muscles. So if that nerve or part of our brain or the muscles stop working, our face gets paralyzed. And when it's paralyzed either on one or both sides, it's a dramatic and significant impact in our ability to socialize, communicate, and our quality of life.
So excellent. So facial paralysis is actually one of those things where it actually means what it is. Many times we call things and that doesn't mean it. Your face is paralyzed. And so as you mentioned, the face movement or animation, as we call it, it starts in the brain, then it runs through a bunch of conduits or pipes, and then it ends at a muscle that actually ends up doing what you asked it to do. So like you said, you could get damage or non-function or something can go wrong anywhere from the brain, the conduits, which are the nerves, and or the muscles. Excellent. Awesome. So the next question is, everyone's like, oh shit, that sounds awful. Oh my God, why the hell does that happen? Is that going to happen to me? Should I worry about this? Is this something that I'm going to it's going to happen tomorrow? So what are the various causes of facial paralysis?
So first of all, it is awful because it just really tremendously impacts people's lives unbelievably. So the first thing people worry about if they see someone whose face isn't moving, they think, oh my God, this person had a stroke. And stroke, which occurs in the brain, obviously, can be one of the causes of facial paralysis, but most of the time it is reversible, or the stroke, unfortunately, is so severe that the individual does not survive. So stroke is one of the reasons, but the most common cause of facial paralysis is Bell's palsy, which happens to be related to the cold virus, the HSV virus that we can have on our lips.
I mean herpes.
Herpes virus.
Yeah. So all you people,
not the genital herpes. This is
Well, all you people going around kissing a bunch of random ass people, getting cold sore herpes, that herpes can come back, cause facial paralysis. I mean, talk to Justin Bieber, right?
Yeah. Um, so Justin Bieber actually had a different type of problem. He had something called Ramsay-Hunt syndrome, and that's caused by a different virus. That's the
Oh,
shingles or chickenpox virus. So these two
oh,
viruses can cause facial paralysis. Most of the time, those are reversible in about 80 to 90% of people. In about 10%, they can have residual impact. Other causes of facial paralysis can be born with it, like Mobius syndrome, it's a congenital syndrome. You could have brain tumors, benign brain tumors that, while they're removed by the surgeon, can result in facial paralysis, or parotid or salivary gland tumors. Those are kind of the most common reasons we see individuals with facial
got it.
paralysis.
Got it. So, in summary, the things that cause facial paralysis can be, again, there are three real main, if you will, mechanical parts to the movement of your face: the brain, the pipes, and the muscles. The pipes, again, being the nerves. So you can have issues occurring in the brain, like a stroke or a tumor or whatever. You can have issues, which are the more common ones, occurring in the nerves, which would be these viruses that we actually all have. And many of us, or 75% of us, have been exposed to during life. It's just that in certain people, they wake up from their dormancy and whatnot. It could be a flu, a cold, stress, et cetera. And then instead of coming back as the flu or the cold sore, come back down the channels and present themselves elsewhere. Or third of all, you're just born with some congenital deficiencies. You can also have it traumatically, right? You could have like car accident, knife fall on your face, something crazy, and actually sever the nerve. Facelifts. Ah, yes. I did a
Yes.
facelift on Friday, and
So,
I can tell you, I was stressed.
so traumatic injuries or trauma is a cause, and fractures of the bone where those pipes and wires travel through can result in facial paralysis. Surgery, like joint surgery, or even facelift surgeries, can result in facial paralysis. Or, as you said, nicks, cutting, those can also result in facial paralysis.
Well, the good news is that the most common cause, which are these nerve inflaming viruses, tend to be essentially 100% reversible, if not 95, 98% reversible. So that's the good news. So I don't think anyone needs to run out in.
It's
90%.
Yeah,
Okay,
90%.
90%. So the next question is,
yeah, it can cause some issues as well. So
okay. So you get this, or one of these horrible things happen to you, and you just call your local plastic surgeon, right? You just like, hey, I got this facial paralysis thing, and or is there indeed, as you are, there's people who deal with this, right? There's experts in the field of facial paralysis, right? What are the training, or what are the things you need to know?
Okay, so there's really, I would say, three phases to this problem. One is you wake up, your face isn't moving. You have to go to the emergency room right away, because you have to be seen to make sure you don't have a stroke, you don't have some other issue that's going on, and you got to get started. If there's nothing that's found, they're going to assume you have Bell's palsy. They're going to start you on steroids, antiviral, and you go on your way. Then the second phase is, if you've been treated for something that they don't know why you got it, but your face doesn't get any return of function, that's the time that you got to go to a facial nerve expert. Because sometimes people think they have Bell's palsy, but they actually have a brain tumor or some other issue. So the diagnosis needs some work in those first 3 to 6 months. But the third group is someone who's had it for a long time. And that is kind of where plastic surgeons and facial reanimation experts come into play, because it's a very, very specialized area with very complicated thought process and algorithms that we need to use to get the best results.
Okay, so excellently said. So there are different phases as this will present. Well, one is you wake up one morning, you're like, holy shit, I can't move half my face, which is actually the most common way these things present, because they usually present through Bell's palsy or one of these nerve things,
Yes.
at which time you got to go and get kind of more urgent care. Most people end up going to their primary doctor or emergency room. And to the best of their ability, they'll try to diagnose you with anything horrific, but often it'll be said, hey, listen, you got Bell's palsy or one of these virally driven nerve inflammation things. It will usually, as you said, in 90% of the case, be transient, resolve in a few weeks to a month. And in the meantime, let's give you a bunch of drugs that are going to cool things off. Steroids cool things off. Antivirals cool things off. And the rest of it is just sort of managing the situation. You want to make sure, as you said, you don't have a stroke. The second thing is that, it's not getting better. No one knows exactly why it is. And you're going to see someone who's a nerve specialist to dig further in, okay, if it's not these more common causes, Bell palsy, et cetera, what else could be causing it? Like you said, a parotid tumor, something in the brain, et cetera. And the area where nerve surgeons, that's not correct. Actually, the correct way of saying it is if facial paralysis experts come in, is in the area where this is now fixed. It just is. Whatever the cause was, it's not coming back. Better. Right. Yeah. And I think we say that's about 18 months. Is that correct? Is that the window where what do you call that framework?
Yeah. So it used to be 12 months. Now we're moving that up a little bit closer to about 6 months, because if someone, let's say, had an acoustic neuroma, the tumor was removed, the face is paralyzed, it's not getting better in 6 months, we don't want to let that muscle remain atrophied for a long time. The earlier we can go and revive the muscles with other nerve transfers, we give the individual the best chance of getting a great result. On the other hand, I've seen patients who've had Bell's palsy for 45 years, and they have residual impact, and we're still able to do procedures to help them smile better, function better. So typically that 6-month window is really important for people who are completely paralyzed. For people who have transient paralysis but not complete resolution, 12 to 18 months.
Okay. So let's say we're going to drive it into two non-surgical and surgical scenarios. So, if you're the non-surgical, you're one of these individuals who had let's say a virally driven Bell's palsy. And the question is, the treatments we discussed, other than the treatments which are the steroids, antivirals, maybe some anti-inflammatories, what other sort of cutting edge, or what other items should, if someone who gets Bell's palsy should consider? Because I know that early onset of treatment makes a difference. So what are the other items that they should do in the non-surgical world?
Yeah, so immediately, really not much other than the steroids and antiviral. But at 6 to 9 months, 12 months, if they still have residual issues, the residual issues tend to be the nerve has regenerated, but it's almost over-regenerated or irregularly regenerated. So people don't have like floppiness. They don't look like they have paralysis. They look like they have a cramp in their face. So in those patients, there are two non-surgical and one surgical treatment option. The two non-surgicals tend to be Botox, because we almost have to reduce the overactivity of the muscles, and physical therapy, stretching therapies, and so forth to stretch things and relax the muscles. And if that's not effective, then I've actually developed a surgery called a selective neurolysis, where we go in and actually identify the nerves and muscles and discreetly and very precisely reduce the overactive muscles that are preventing their smile from being ideal. So Botox, physical therapy, stretching, and some surgical options are available.
I think that's very interesting. Let's chat a little bit about Botox, because everyone's so enamored with Botox and its cosmetic benefits. But we both know that Botox originated in the medical arena for blepharospasm, or things that were due to hyperactivity of muscles. And people would get the Botox to soften or relax those muscles because they were overactive. And this is exactly one such case where, the nerves shut down for a while, and it's not uncommon they come back as hypersensitive or hyperactive, or as you said, not in synchrony. The messaging isn't clear. And so you want to selectively reduce or eliminate or modulate the activity. The other interesting thing is also that while you're waiting for your nerve function to come back, don't you guys use Botox on the other side to create a little more balance? Because now you have a, say, weak side that's healing, coming back, functioning, kind of not there. And then you have a normal side that's fully firing at all cylinders. Tell me a little about this balancing act that you can use Botox for in order to kind of wait and let this come back to normal.
Yeah. So natural facial appearance and smile is, for instance, balance in your forehead movement, balance in your smile, balance in the teeth show. So you can use Botox on the opposite side to create an optical illusion. For instance, if one eyebrow is moving, the other isn't, you could, just like we do for cosmetic reasons, Botox that muscle, the frontalis muscle. If the smile, the teeth show on one side is a lot more active than the other side, you could target little muscles to help improve the overactivity on the normal side. So it's to create, Botox is wonderful to create an optical illusion of symmetry.
Right. I mean, and it's actually incredibly powerful. And I had a quick question for you because this has come up before. If a person has had a history of Bell's palsy or any type of facial paralysis or neurogenic related weakness, and they have some residual that never went away. So maybe you know someone who had a history of Bell's palsy as a child, and as Dr. Azizzadeh said, 90% of the muscle came back. But if you're an astute observer, you notice a little bit of an eye change, maybe a little bit change in their grimace, etc. Are you is it ill-advised to use Botox in those individuals? Are their nerves more sensitive to paralysis? Or is it, nah, whatever it is, it's just a matter of balancing?
They're ideal for our utilization because those nerves have healed, right? But now they're functioning differently, right? So now Botox, we're really targeting at the muscle level because Botox relaxes muscle. So if their eyes like really twitching, it's like a blepharospasm. You Botox it to calm it down. Or if a lot of times they get overactivity of the platysma muscle, which is this neck muscle, or the muscle that pulls the corner of the mouth down. So we can target those with Botox or nerve surgery actually to help them smile better and not have this, kind of irregular smile and eye activity.
Okay, well, I'm fascinated and shit. I know all this stuff from before and I find this interesting. So we're going to take a quick break. We're going to come back. I want to talk a little bit about the really holy shit cool stuff that you do, which is the surgical intervention for that third category of patient, which is unfortunately the nerve function never returned. The muscles that they used to function have atrophied and are non-functioning or are about to become non-functioning, and what those surgical options are. So if you want to know about that, you better hang tight. And we'll be right back with Plastic Surgery Uncensored. All right, welcome back to the second half of Plastic Surgery Uncensored. It's myself, Dr. Azizzadeh, and we are talking all things facial paralysis. So, Babak, tell me about what I think is really the coolest shit that, I mean, you do a lot of cool shit, but I think this is the coolest stuff that you do, which is facial reanimation and how nerves and the connections and, it's very complicated. So it's going to be hard to talk about in a brief conversation, but let's give it a stab.
Yeah. So basically, let's kind of give an example. There are some children that are born without a smile on one or both sides of their face. If it's on one side, we're going to assume, and it's absolutely true, that their muscles have not developed for one reason or another. So if someone's muscle hasn't developed, or the muscle has just atrophied because they've had paralysis for a long time, we have to replace that muscle. We have to bring in a new muscle to help them smile. There's no other way. The most common muscle we use is a muscle that we get, teeny muscle we get from the inner thigh. It's called the gracilis muscle. And that muscle is basically, we bring it up with its artery, vein, and nerve. But this is where it's really, really important. So if someone's just paralyzed on one side of their face, we want to borrow nerve activity from the natural side of their face. Because what we want to do is give that child or adult an ability to smile naturally and emotionally. because 99% of our facial expressions we're not conscious of. We're just smiling, we're just laughing. And so we usually put an extension cord called a nerve graft to the opposite side of the face and attach that nerve graft to this muscle. And therefore, when the muscle gets high and it heals and the face heals, that young child or adult can smile naturally and emotionally. So we've replaced the lost muscle or the failed muscle. So that's the most common way that we're able to help an individual who has no muscle activity and has been really, really, lost all activity and hasn't come back.
So wait, before you go on, because for those of you listening, what was just described is nothing shy of extraordinary. So it's up on the list of face transplant. It's up on the list of, burn surgery. It's really complicated stuff. So I'm going to reiterate it just a little bit again so you can understand. So, people assume, oh, nerve damage, just repair the nerves. It doesn't work that way. It's much, much, much more complicated. So in the scenario that Dr. Azizzadeh described, a person doesn't have the function of one side. So you borrow the necessary machinery to make that side move. So what are the machinery? It's the muscle, and that muscle needs stuff. It needs an artery because it's going to die, and it needs nerves because nerves tell it what to do. And the thing that's so fascinating about this is, unlike moving muscles around on the body, which we've done for quite some time, which we call a free flap, we're borrowing it, we stick it from your back onto your breast, blah, blah, blah. This one's unique in that it not only has to have a blood supply, but it has to function. Now, the reason why this is unique is if you plug in that muscle onto the right side of the face and you plug that artery into the right side of the face and you go to plug in the nerve on the right side of the face, you're going to have an issue because A, there may not be that nerve, and B, whatever nerves are there may not communicate to the nerve on the other side. Because when you smile, you tend to do it a little bit symmetrically or in concert. So it's incredible that you go before the surgery, you find the nerve on the normal side, you put, as Dr. Azizzadeh eloquently put it, an extension cord, which is another nerve that you borrow from somewhere else, cross it over, you still do it over the lip?
Under the lip, yes.
Under the lip, onto the other side. And then you go back, you take a muscle from inside the thigh, bring it into the face, sew it in there, and then connect its nerve to the left side nerve that's coming across and plug it in so that when the person smiles naturally from the left side, it fires the muscle you borrowed on the right side. I mean, if your head doesn't explode, I don't really know what else to tell you. Because to me, that's just
the coolest. It is the coolest thing in the world.
It's unbelievable, unbelievable. So what kind of quality of life? I mean, we sometimes in medicine, us doctors get all geeked out. We get so excited. We do all kinds of cool shit. But let's be honest. Sometimes the quality of life, what we're going to go do, doesn't end up leaving the patient with such a high quality of life. One such example is burn surgery. Burn surgery, we keep the patient alive. We put skin grafts, but seldom does a patient return to a high functioning quality of life if they've had significant burns, because skin grafting is shit and it's not good and it contracts and blah, blah, blah. But facial reanimation, at least high level facial reanimation, seems, from all of the amazing work you publish and put online, pretty good. So what can people expect for a quality of life regarding these types of surgeries?
Well, I think the quality of life for these, again, children and adults can be quite good. But as I explained to individuals, when I was training, and this is just maybe a couple of years ahead of your training, the goal was just to get movement. There was very little attention paid to the aesthetic outcome, the symmetry, the transition zones of the face. And that's one of the I really try to change over the last 20 years, where thinking about the aesthetic and the reconstructive, the smile and symmetry and aesthetic side really changed I think, a significant amount in terms of outcomes. And the quality of life for patients can be dramatically great. Now, as I tell everyone, once your nerve is damaged, it's really hard for us to get it back to perfection. But we're now getting really closer and closer to phenomenal outcomes that are impacting. And, we have so many children that are going to college, are getting married, have meaningful jobs. That's what we want, right? We want the kids to be able to be a part of society, not just be able to smile. So quality of life can be quite good, much better than burn, better than face transplant, better than head and neck reconstruction where we're redoing the jawbone or the tongue and people are still on with trachs or they can't swallow. So quality of life can be quite dramatically better.
And I think what you said, it is really something that people don't appreciate unless you're in the field of medicine, is that medicine is we discover, we create, we come up with a new idea. And then it generally takes 20 to 30 years for people who come after that idea was developed for the refinement of that idea. So what Dr. Azizzadeh was referring to was the first milestone was getting some muscle from some part of your body, smacking it inside the face, connecting it, making it fire and work. And that's like just getting a plane off the ground and not crashing to the ground. And the Wright brothers are that, just can we get off the ground and hover for 45 seconds? And today, surgeons like Dr. Azizzadeh are in the nuance phases of that such trajectory of that surgery, where they're worried about, no, this muscle's a little bit too thick. Let's shave a little bit. It's going to create a bulge. The length of the muscle and how much the mouth moves up and down relative to the other side. And so, as you was referring to, the aesthetics. And the same is true of rhinoplasty, which is one of my favorite things to do. People did mediocre nose jobs because that's all they knew. 50 years later, now we're doing some cool ass shit. So medicine, hence the practice of medicine, is really about this. And I think that you're absolutely right. In the area of facial reanimation, you guys are doing some extraordinarily refined work. And then at the end of the day, the goal is, you said, to re-enter society without anybody knowing. So, kudos to you. What is the current biggest obstacle in facial reanimation? Like, God damn it. Like in breast surgery, the biggest obstacle is capsular contracture. Right now, despite all the blah, 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 and this, that, the other, whatever, we're still kind of getting sucker punched by capsular contracture. So what is the biggest persistent hurdle in facial reanimation?
Well, there's two factors. There is still a level of unpredictability in how muscles and nerves regenerate. We don't have exact, delicate, this is what's going to happen. Like in rhinoplasty right now, you said it perfectly. If you take 2 millimeters from the dome, you bring it together, you could have a lot more of an idea of what the outcome is going to be, rather than in reanimation, where there's some unpredictability in nerve regeneration and muscle regeneration. That's one. Number two, I think still one of the biggest hurdles is individuals who have Mobius syndrome, bilateral facial paralysis. I think the results are, because we don't have a natural side to borrow from. So we got to recreate it on both sides with nerves that are not coming from the area that gives us our smile. So it's still not, to me, it's still the results are good, not great. So that's kind of like, there's a couple of nuances that I'm doing now that hopefully will impact that positively in the, maybe 10 years from now when I'm on this podcast again. But those are, I would say, those are the two big things right now that are still really frustrating.
I think that, I think the 20 years ago it was the free tissue transfer, was like keeping this muscle alive, connecting it. That part we've hammered down. We can do 97%, successfully arterial anastomosis, venous anastomosis. The inset of the muscle, you guys have gotten down and figured out the width of the muscle. So it sounds like the area that's still a little bit tricky is just understanding nerve anatomy at a microscopic level and its sort of predictability of how nerve regeneration is. Is there anything on so that kind of segues into my last and sort of final question, which is what things are in the horizon, right? So to me, it sounds like the people who are working on the regenerative side of medicine, and imagine you could in a lab create the perfect conduit nervous system that you could plug in end to end, almost like plug into socket. Because right now, unless it's changed, when you do nerve to nerve anastomosis, it's kind of sheath to sheath, and if you have some large bundles, maybe, but these are tiny. You're still using sural nerve or
nerve.
So there's not I don't know if people understand. It's just tiny little nerve, and while you're doing it under the microscope, you're just kind of sewing the ends together, and you're hoping for the body to manage its way across. I wonder what's happening in the coupling of nerves, and or what are the other exciting things that they're not ready yet, but I see this being a game changer.
Couple of things. I'm actually working with a artificial muscle lab at UCLA that may help dramatically, because it's not just your smile, it's your eye, right? Can help potentially with blinking and other facets, because blinking, just like a smile, is really, really complex and is controlled by the facial nerve action. I think there are newer nerve regeneration approaches over the next decade or so that will help give us a little bit more predictability in how the nerve regenerates. And there are also surgical innovations that I was talking about for patients who had partial paralysis. These muscle transfers were unnecessary, and that's one area that over the last 5 to 7 years, I've really changed, hopefully, people's minds about doing muscle transfers and so forth in them, and just really essentially rewiring their own nerves and muscles to help them smile better. So there are a lot of advances, but there isn't as much funding for this type of work. So research is done by very, very few places around the country and around the world. So it's going to be a little bit slower than some of the other fields in medicine that have better funding.
Are there any drugs that one can? I don't think there's a drug that's going to help with nerve regeneration. It's too broad a concept. But I'm talking about maybe that can be locally placed or done, because a lot of this is what people understand. So let's go over about nerves. So when a nerve is cut, it retreats all the way back to the beginning and has to grow all over again. It isn't like an artery that's a tube and you put the two ends together and then push blood through it and it works. It's not a hose. It's the nerve dies and goes all the way back and then has to regenerate through that tube. So are there any such stimulants, like, how we're doing PRP and fibroblast stimulating growth factor, blah, blah, blah. We've been talking about that for 15, 20 years. Have they found any nerve related?
It's actually interesting. I'm actually going to be a part of a clinical trial as we speak about that, where there is a local administration of a product.
See, I'm not so dumb after all.
No, you're right. Spot on. That helps reduce the demyelination of the distal aspect, which is like a nerdy talk for that loss of nerve that happens when a nerve gets cut. So there will be. It's just, the issue is that it's not the most common thing in the world. It's not like high blood pressure, right? So, or cardiac disease. So the funding and research, and actually the drug companies' incentives to do research and put money behind it is a little bit less than some of the other areas.
So I have a solution for that. Now you have a global spokesperson. You reach out to Bieber, and now that he's been impacted by this, at least facial. By the way, did he get all of his facial? He disappeared for a while, obviously. Did you know of if his facial reanimation resumed, got back to 100%, or does he still have some residual weakness?
I'm not sure if it's 100%, but he's gotten a significant amount of it back.
So he's your guy. He's your new poster child. If you notice in medicine, what you said is exactly right. It's about funding. It's about exposure. It's about awareness, right? Remember the ALS challenge? Remember the bucket challenge?
The water, yeah.
Right? So what the hell? I was just watching Instagram and I saw Michael Jordan doing it, right? And it had gotten, that trend on social media brought Lou Gehrig's and ALS onto the screen 10,000-fold greater than its effect, how many people it affects in the world. And, I'm being facetious at the same time, not really, but, at least Bell's palsy is not that uncommon. First, facial nerve.
Common, yeah.
So, luckily it resolves and whatnot mostly. But anyway, if you want me to reach out to Justin, I can for you. If you just, let me know if you want him to be a poster child.
Sounds amazing. Amazing.
Well, I don't. Is there anything else that I'm missing here, Mr. Facial paralysis expert?
No, it's so refreshing to talk to someone who knows so much about this. I know it's not like an area that you are actively operating in, but I do want to tell everyone that one of the first times we've known each other for a long time, but one of the first times that I saw you were in residency. And you were doing a surgery with Ron Zucker, who is one of the godfathers of facial reanimation.
That's true.
At Cedars, and I walked in, and you were operating with him, and I was hanging out and watching very quietly. And you were a resident then, and I had just started my practice. So that is our facial reanimation connection.
Yes, and
you remember that.
I do, and I find it so fascinating. Yes, it's not something that I do at all, and nor should I. And this is why I have you here. And in a minute, I'm going to get your information for those individuals who know people or want to reach out, et cetera. But this is an area that you specialize in. You're a specialist. You do all kinds of amazing things, a lot of aesthetics, beautiful work. But this is area that very few people do because it requires so much dedication. I can tell you that in order to get excellent at anything, any procedure, I don't even care if it's removing a goddamn mole, you got to do hundreds of them before you get the nuances down to go from, oh, it's okay, to, wow, this guy is spectacular. So imagine trying to do hundreds of facial reanimations. It's very hard to do. So you definitely got to dedicate yourself, which I know you have. And in a world full of slimy plastic surgeons and aesthetic surgeons that we both rub elbows with and come across every day, it's really lovely to have somebody who's remained pure and academic and lovely and honest and good. So for those people who want to follow you, reach out to you, ask you questions regarding anything in the realm of facial reanimation and or otherwise. So Babak Azizzadeh is Babak, and Azizzadeh is Azizadeh. So what are your handles, schmandles, and where else can they find you?
The main one is at Dr. Azizzadeh, Azizzadeh. That should kind of give all the information at Dr. Azizzadeh.
Awesome sauce. All right. Well, I really appreciate you taking your weekend, an hour of your weekend to spend with us. Hopefully you guys found that to be interesting. I'm sure next week we'll have something really fascinating. In the meantime, if you like our show, I don't know, say something nice, write something nice, share it with a friend, download an episode, keep us floating. All right. Until next week, it's always a pleasure. Signing off on Plastic Surgery Uncensored.